and taking you through a sort of soft introduction into statistical analysis that we've been doing on the WYSIC data. We're mainly focusing on the WYSIC data because that's at the moment what we have a full picture of. So all of the information that we need from it for the final analysis. And I'll be starting off with a sort of quick introduction into what WYSIC contains. So WYSIC is the Northwest London data hub for healthcare data. It contains at the moment around almost 4 million patients, but back at the start of the pandemic, it was 3.5 million. So that's the baseline that we're going with. And from this pool of patients, we identified patients that were coded with having long COVID using primarily two codes, post-COVID-19 syndrome and post-acute COVID-19 disorder. We've originally also used post-viral syndrome, but it turned out to give quite heavy outliers, and by excluding it, we excluded only 3 patients in total. So it was sort of code. But using just these two codes, we ended up with 4,666 cases of non-COVID reported since January 1st, 2019. It's significantly lower than I personally expected, especially looking at ONS data where their estimate is 320,000. So with a pool of 3.5 million patients, we expected this to be at least 2 times higher. So there is quite heavy sort of underreporting going on of long COVID patients. As a quick look at the demographic data of those 4,666 patients, looking at the mean age of 48.3, which lines up with showing, and a very heavy split in gender. Looking at twice the number of female patients than male patients, which highlights the recurring recruitment issue that other groups have had, where they see an overrepresentation of middle-aged white female patients that can get recruited, and heavy underrepresentation of either different age groups or different ethnicities. Especially with black patients, we see a very, very low percentage of them compared to both the areas and the impact that we expected them to have. As part of analyzing our analyzing the WYSIC data, what we've done is we've decided to apply an algorithm on classifying comorbidities to patients based on the appearance of certain SNOMED codes. This algorithm is originally used in ORCID, and it's very extensive. It's like hundreds of SNOMED codes to a particular disease. Like, for example, if you wanted to see if a patient has asthma, there is no single SNOMED code that would describe all of the possible ways that they could be tagged with asthma. TADS allows us to actually generate that list and assign them to the patient. What we've done is we've taken those codes for about 20 to 30 common conditions, translated them into the WYSIC environment, and applied the same algorithm onto our study population, both onto the original 3.5 million and onto the 4,666 non-COVID patients. And some of the results are more or less expected. Chronic lung disease is twice as prevalent. Asthma is twice as prevalent. COPD is almost twice as prevalent. But I think what this also helped me understand, and I think it helps highlight, is just how significant the impact of mental health is on this condition, with depressive disorder being 131% higher prevalence that reaches 21% of patients. Anxiety disorder going up to 24%. Every 4th patient, long COVID patient in the WYSIC data set this type of anxiety disorder, which highlights this earlier focus that was brought on during one of the workshops on integrating mental health care into long-COVID clinics to help resolve these underlying issues as well. The last 2 points highlight 2 distinct perhaps quirks of the data that we've encountered so far. Cirrhosis of the liver presents with a 3,257% increase in prevalence. For me, it doesn't look like a 33 times increase. It looks like a problem with the coding. So phenomena like these, where we see an unnaturally large increase or unnaturally large decrease, highlight to us that we need to do our due diligence as well when importing these stats variables. We haven't trusted Oxford to develop them correctly, but clearly there might still be either underlying issues in variables themselves, or in the coding, or in their picking up. And last point, with disorder of immune function actually being lower in long COVID patients, at least for me, brings more attention to perhaps the theory that long COVID is more of an immunological disease, and all these recent papers highlighting the immunological disturbances that are presented in COVID, potential treatments through that. There might be some weight to that, and this could be a pathway to be explored further when sort of looking deeper at what TADS actually picks up as immunological disturbances. Is it something significant? Is it something we could look deeper into? But it is a significant decrease, 70%. Moving on from comorbidities, when we just focus on long COVID actual diagnosis, we can plot the number of diagnoses over time. We're starting off at when the diagnosis just about popped up around November 2020. There's 2 distinct peaks, both around March 21 and 22. And then since March 22, there's been a steady decline for over a year now. Now, part of this decline, especially the most recent ones, just time lag in reporting and getting the data imported. But it's been steadily increasing, and as we generated a similar graph before a few months ago, we've already seen the steady decrease, and it hasn't stopped. So the question sort of we find ourselves asking is, where does this go? Does this just drop off completely, and why is this happening? Similarly, when looking at non-clinic referrals, you can see 2 peaks, and ever since that, this is a bit later, June-ish, 2022, there's been a steady decrease in referrals to clinics. Even though we see that there's a huge need for them, there's being put into them. For some reason, clinicians are not referring patients to clinics. Why is that? Another question when looking at these 2 graphs we ask ourselves is, what's the time difference between somebody having their first diagnosis of long COVID and actually being referred to a long COVID clinic? Now, when looking at the results of this, we got an average duration of 49 days. So 49 days after their first diagnosis with long COVID, the patient is referred to a long COVID clinic, which is arguably a bit too long. It's almost 2 months of not receiving the specialized care that they would. What we did expect was to see this sort of long tail as perhaps patients are diagnosed with long COVID, but they don't have access to a long COVID clinic, so they cannot be referred to one, or maybe there's a waiting list for some reason. But what was perhaps more shocking is that on the left side, there is about 30% of patients who were referred to a long COVID clinic before they received long COVID diagnosis. It's based on the data. This doesn't make much sense logically. At least to me, it highlights a very big issue that one of the previous graphs, one of the previous ways of looking at the data showed that there's potentially very serious problems in how long COVID and referrals to long COVID clinics are coded. Now, we're still looking into this just to decipher to see if is it a problem with coding long COVID, or is it the referrals, or is it something else? Is it perhaps a problem with the HR system handles dates? But it still remains that something is wrong there. And it could be a sign of a more serious matter, because any analysis that we do on this will be undermined by the fact that the coding itself. When we look at, say, resource cost utilization in SAS data, what my coworkers now have been looking at, it's difficult for us to say with confidence that we know the date when a patient developed long COVID. So we thought we'd look at it as the previous graph is more new. So now we're looking at the number of appointments that patients see before they develop long COVID and after they develop. So blue is the cumulative number of appointments that patients have before long COVID, and orange is after they have having long COVID. Now there is a very clear increase in overall number of appointments. That much is clear. The more complex thing that we need to disentangle on this graph is how many of those appointments are tied to long COVID clinics specifically, and what kind of appointments are they? Are they serious appointments that require hospitalizations, or are they just checkups? Are they specialist appointments? Are they whatever they are? We're looking into quantifying that and getting a better picture of actual pathways that patients go through in long COVID. As part of looking at those appointments, we also looked at readmittance following any secondary care appointment, looking at patients who perhaps were not receiving the right treatment and they had to repeatedly get readmitted back into the healthcare system. And we found that there is a large number, vast majority of patients have had to get readmitted within 2 weeks having an appointment, which at least for me is a surprisingly large number. And well, we did earlier bring up this problem of patients being referred to a specialist and then specialists ignoring them and then being lost in the system. I think the other extreme, patients who keep getting readmitted, is also a group of patients that's very worth looking at to see where they are getting readmitted, for what they get readmitted, and what can we learn from that. So just as a quick summary, there's a lot of concerns to be had with the way long COVID data is at the moment coded in HR systems, but these concerns also are solved and present us with very valuable information on comorbidities and characteristics of long COVID patients that separate them from either normal patients or patients who had long COVID, who had COVID but didn't develop long COVID. There's also concerns about the actual secondary care appointments. Where are these patients going? are they getting readmitted the most, which those secondary care appointments are actually working, and we don't see the readmittance of those patients. We're still working on that. For our next plans for the next few months, we will be looking at phenotyping on identifying the symptoms to look at addressing this issue of underreporting non-COVID patients. This will be mainly done by a group at King's College London, headed by Vasa. We're looking at validating the differences in comorbidities that we saw, ensuring that the patient character, the underlying patient demographics are the same, and that the only thing influencing this difference and prevalence is long COVID. Once we do get access to the ORCID dataset, we will want the exact same analysis on ORCID to get the validation of our findings and to see if there is any difference. And lastly, we'll also be looking at identifying pathways within non-COVID clinics. So similar to what Joseph mentioned. How exactly these patients are going through these clinics, maybe not going into too much complexity, but to give us an idea of what seems to be working